This is my presentation. It's a zero contrast PCI in ACS. For the zero contrast PCI, first I want to say is that we have to carefully evaluate the indication because this procedure is high risk, of course. And intracoronary imaging guidance will be performed in whole workflow, including morphology evaluation and help us choose appropriate device to pre-treatment and for the evaluate the treatment effect if we should accelerate our procedure and optimize the final result. And if some complications happen, help us to find what's the underlying mechanisms. And here's some tips and tricks. We should use the reference image with the same projection during our procedure, and using the workhouse gateways you know best, and using softwares. I recommend to use them looped for the tip of the wire and keep it in your screen, and to prevent some complications. And using marker wires, multiple marker wires, and average tip, reps, and some markers for your position, and using the techniques of the stand boost or clear stand that helps you not using any contrast. And here's a case example. It's a 69 years old male patient. They performed a coronary CTA. CT angiography 6 years ago and have some contrast allergy. And 5 years ago, the patient has come angina and perform coronary angiography and have an anaphylactic shock because of contrast medium. And because of that, the patient cannot do any PCI at this hospital and optical medical therapy since 2019. The patient have chest pain worsening 3 days, and the CHOP-I is 1.1 nanogram per milliliters. The echo shows ejection fraction is normal. Here's the EKG. And this 5 years ago angio shows that the media LED has very disease stenosis, maybe more than 80%. From the cranial view, also shows the media LED stenosis and the proximal diagnosis. The circ and the RCA looks normal. Here's the 5 years ago. But for this time, this patient is non-STEMI and severe anaphylactic shock. And so this patient is reasonable for us to perform a zero contrast PCI guided by hours. Here we perform the 3 vessel hours to identify what's the carpet lesion. So for the RCA, the hours showing just a normal. And mid-RCA have intermediate lesion. Minimal lumen area is 4.8 millimeter square. We also perform the FFR derived from iris imaging. We call it the UFR. The UFR is 0.85 for this patient. For the RCA, it looks good enough. For the circ, the UFR is 0.99. It's quite normal. MLA is 6.9 millimeter square. And so the carpal lesion still, we believe it is still LAD. We use the reference imaging and to guide us to varying this patient, this LAD and diagonal. And this LAD from distal. Distal looks good. There is some coming some plaque, eccentric plaque. Incoming ascent branch. As something more disease. and calcium. And for this diagonal coming, and this here's some stenosis, very eccentric, and then coming the MLA side. And MLA is 2.3 millimeter square. And the UFR for LED is 0.7. We think it's the carpet lesion. And we also performed the errors from diagonal to LED. The UFR for the diagonal is 0.86, and the osteum diagonal is MLA is 2.5 millimeter square. So for this patient, the LED have some calcium, but also it has 360 degree calcium, but without calcium nodule. The segment of calcium, the degree greater than 270 is only 3.3 millimeter. It looks like a superficial calcium, but very short. It also has multiple reverberations. The vessel size bigger than 35 millimeters. So the calcium scoring for this based on errors is only 1. We believe this could have a good standing expansion without some more aggressive procedure like ROTA and IVL. So we just using cutting balloon. 30 by 10 millimeters is 12 to 16 atmosphere, and the lesion, we believe the lesion is fully expansion. And then we use an NC balloon 30 by 12 millimeters using 18 to 20 atmosphere. This hours after the cutting balloon, we can clearly see the good correct rupture of the calcium after cutting balloon. So we try to do the standing, and we use the multiple marker wire for the first diagonal and second diagonal, and to help us to positioning the standing, the distal landing zone. We choose the 30 by 32 millimeters DES. And for the side branch, the osteum diagonal is not so bad, and the plaque distribution is most opposite of the side branch. So we use the ballooning protection technique. We call it the ballooning standing kissing technique, using a 2 by 15 millimeter complete balloon to protect the side branch. And here's a rewiring diagonal and post dilatation using NC balloon 35 by 15. And here's the final errors. And the UFR is 0.98. It's good enough. And the MSA for the LED is 6.4 millimeters. Here's a pre and after cutting balloon and post errors. The baseline errors show that the MLA is 2.3 and the final errors MSA is 6.4 millimeters square. UFR from 0.6 to 0.98. Now here's a 6 months follow-up. The patient have no symptom, and we also performed the myocardial perfusion imaging, show that no ischemia. Here's the take-home message. Zero contrast PCI is a feasible approach for indicated patients. Intracoronary imaging is necessary. Of course, it should be interpreted correctly. And a final, zero contrast is not a means, it's a means, not a goal. Safety, but patient safety is always first. Thank you.